thought what I do is I got 15, 20 minutes. We'll go through 15, 20 notes or so on stats and notes regarding spine practice, spine business, and so forth. Before we get started, I take it the audience, largely residents and fellows. So fantastic what you're doing, and then lots of spine surgeons themselves. I want to thank you for having me. A couple things I'll just start off with before we get going. I'm by background two things. I'm a lawyer. Then I'm also the founder of something called Beckers Healthcare, including Becker Spine and Orthopedics. And the one thing I'll tell you in terms of my talk and stats and notes, the level of accuracy for journalists is much lower than the level of accuracy needed for spine surgeons. So if something's not perfectly accurate, it's okay because I'm more of a journalist and a lawyer than a spine surgeon, so it'll be okay. The other thing I'll tell you is just as background, as people start their careers and so forth, the only two sort of starting points I'll get to before I start getting on stats and notes about the business of spine is this concept of as you get older, as you get into your career, taking care of your own physical and mental health becomes an absolute critical priority that you ought to think about from the get-go. The only other general advice I'll give, and aside from taking care of your physical and mental health, is to start early taking care of your financial health. I know after 4 years of med school, many, many years of residency and fellowship, some people are so excited to buy the big house or drive the fancy car. And what I'll tell you is it's a huge mistake. And the more that you take care of your financial health and your physical mental health, the more freedom you'll have a lot later. So that's sort of the extent of sort of the sort of preface to my comments on what's going on in the world of neurosurgery and spine surgery. So in terms of, again, just background, I spent a lot of time over the years in the surgery center space and then with spine practices and other types of sort of, and spent my time as a lawyer in this mix of surgery center chains, hospitals and health systems, and private equity funds that invest in healthcare. By background, because somebody from Harvard can never fail to mention this, I went to Harvard Law School, and just as a credentialing thing and not to be obnoxious. But so to go forward, between neurosurgeons and orthopedic trained spine surgeons, about 4,500 or so surgeons practicing spine surgeon in the U.S., and increasingly orthopedic spine surgeons drive that. There are about, in terms of the nation, there's about 6,000 what are called Medicare certified surgery centers. And of the 6,000 Medicare certified surgery centers, there's also another couple thousand surgery centers that aren't Medicare certified that typically are for plastic surgery, cosmetics, some other things. But at the nation's surgery centers, there's about 250 to 300 or so, 350 that perform some level of spine surgery. And obviously over the last decade or two, huge movement of surgery to outpatient settings, minimally invasive surgery, less complex spine surgery to surgery centers into outpatient surgery, outpatient centers. And that's a real mix between hospital outpatient departments and true surgery centers. But there's about 250 to 350 surgery centers that perform spine surgery. And not that many of those are solo spine only centers. Most of those are connected to an orthopedic practice or orthopedic physicians, also include pain management. A small number are tied to general multi-specialty surgery centers. But at the end of the day, if you're going to do spine surgery in a surgery center, you really have to be focused around that pretty well. You could do it in combination with orthopedics, you can do it in combination with other things, but it's very hard. And we've seen lots of failures of one-off spine surgeons, one-off spine surgery centers, because often there's a significant cost to operate, and spine surgeons in the same thing as in practice, lots of challenges still from payers. So we've seen surgery centers with spine go up and down dramatically based on what's going on with their payer relationships and whether payers are allowing them to do spine surgery in the surgery center, whether they're getting paid for it, whether they're getting paid well enough for it, and so forth. So most places there's some de-risking that goes on by being part of an orthopedic surgery center and not just a standalone spine center, but there are obviously a certain number of independent spine surgery centers in the country too. In terms of the practice differential between spine and orthopedics, When you look at sort of large spine practices, those typically cap out at 30 to 40. And we'll talk about a little bit later. The dominant local spine group is still a wonderful place to be in terms of practice, in terms of quality of practice, quality of ability to be paid fairly, quality of ability to staff well and to take care of patients while you want to take care of it. But there are a few spine practices that are more than 20 to 30 or so physicians. There's a few, but there's not a lot that are truly of that sort. Whereas orthopedics, there's now a ton of private equity sponsored orthopedic platforms, as well as orthopedic groups that have become very large, 100 plus or so forth. And some of those have a spine component as well, of course. But at the end of the day, the size of general orthopedic practice is much larger than the size of spine practices, and the amount of private equity funding towards orthopedic-driven platforms and practices is significantly higher than towards spine-driven practices and platforms. What we've got, and these numbers again are not exact. What you do, it's much more important to be exact, is approximately 7 to 9% of orthopedic surgeons are still in solo practice, truly some solo practice. That number is getting smaller and smaller. We talk to spine surgeons constantly who have sort of been, we talk to some that have been very successful in solo practice and love it and continue to really thrive at it. But they're somewhat mavericks and a little bit against the grain, but there's a good deal of them. And then we often talk to spine surgeons, like one that we talk to regularly from, Arizona, finally got out of individual practice and went to work as a hospital employee. And he's in a little bit of a smaller area, had trouble recruiting, trouble with call, trouble with other things, but less and less spine surgeons, even though often a very, a group that has a strong independent streak to them, less and less in solo practice. Spine surgeons are generally highly intelligent group of people, often interested in research and teaching. In a good number of the spine surgeons are also quite entrepreneurial, but you do see less and less in what we think of as truly solo practice. But some still in smaller practices, and more oriented to larger systems, larger cities, and where they're in larger groups versus being really independent. In terms of generally throughout the country, 80% plus of doctors are now employed by health systems or hospitals or large corporate entities like Optum, which is a part of United. People that aren't familiar with this, most of you probably follow this and are familiar, but Optum now employs about 70, 80,000 physicians, almost 7%, 8% of all physicians. That's United Healthcare's corporate entity, Optum. So if 80% of all doctors are employed by hospitals, health systems, and places like Optum, that number is lower in spine and orthopedics, but it's certainly significantly rising. The number is probably closer to 60%, and in spine, it's probably a great mix that are employed in some fashion today, but still lots of independent groups and lots of great spine surgeons that work with health systems or academic medical centers and so forth. In terms of spine surgery practice, the thing that I've seen over the years that's probably the most daunting is just the constant payer challenges, pre-authorization challenges that can often make life for surgery centers and spine surgeons quite challenging. And economics can go up or down based on how strongly the payers are pulling the levers on pre-authorization and payer challenges. The defense to it often is sometimes working in larger groups with more ability to fight back or to have enough market power to fight back. But these are constant challenges, and you compile the problem in spine different than either gastroenterology or ophthalmology, for example, where payment is fine for procedures with Medicare, where in contrast with spine, Medicare, Medicaid, often the payments are disastrously low. So you don't have the buffer against the private payer and commercial challenges that you have in gastroenterology, ophthalmology, and some other specialists. We do see, and many of you are familiar with this, some large spine groups and small spine groups that have completely stayed out of Medicare and remained out of network. And some great groups, some of the best groups in the country, have been very much driven by self-pay. You have to, if you're going to be self-pay driven, you've got to be a strong enough brand. You've got to be great at what you do, and you got to be great on sort of the marketing development side as well. and again, as we said earlier, even though solo and small practice is on the decline, we still have at our meetings and still run into lots of spine surgeons that are truly independent practitioners. And I find it really challenging for them to be able to do that. But some of them absolutely love it and like the independence and are able to make it work without being part of a group. So you still see whatever the number is, 7 to 10% of spine surgeons truly independent, which is really remarkable. We don't see a lot of it. I'm in Chicago. We don't see a lot of it here, but talk to people on the coast in different places, and you still see people that are very much driven to be independent practitioners, and they like the independence. But then we see other independent practitioners that have ultimately imploded financially in their practice. Just the sheer burden of all the bureaucracy of the payers, the getting paid, everything else, being able to practice medicine how you want to practice it, makes it, I think, very, very hard to be in a really small group, though you still see some of it. You just can't, it's hard to have the resources to run a group today. Running groups like running a business, it's hard to have the resources today to do it. We do see, in contrast, throughout the country, great dominant local groups. And this has been a fantastic practice model. It's very similar to the great health systems that were regionally strong, regionally dominant, have done much better economically over the last couple of decades than really large spread out systems or really small systems. And it's the same thing with dominant spine groups. I remember a spine group that we were very close with for a very long time. The two local hospitals would constantly try and recruit against them, constantly say, we're going to put you out of business to the large dominant spine group. And after 20, 30 years, still have not been able to do so. And so being part of a strong local group, to me, is still, a great winning solution. The jury's still out on sort of these large national groups, where they really add value or not to the local practice. They might add capital up front. There might be a way for people to exit financially some, but would they really make a difference in the long-term day-to-day practice? I'm not really sure. But what I do know is that the local dominant group, it still tends to be a winning strategy for spine and quite frankly for orthopedics and generally as well. In spine, in many of the groups, as you know, that are in private practice groups, not necessarily health system groups, ancillary services, pain management, physical therapy, imaging, surgery centers, and so forth. And you often need enough critical mass to be able to invest in these, support these, make these go. If you're joining groups in the next few years, people have to decide, am I going to work for a health system? Am I going to work for an independent group? Am I going to go back to the town I came from, which might have been a smaller town, and develop a practice there? And what does it sort of look like over the long run? But the financial stability and ability to thrive often includes lots of ancillary services done intelligently and almost like the same concept of building a house. You're not trying to build a Taj Mahal. You're trying to build your ancillaries and everything you do in a relatively efficient way without so much debt. And that's part of how you stay anti-fragile over the long run. And we talk a lot about anti-fragility, just trying to make yourself anti-fragile, which gives you much more freedom over the long run. And that often means not overly building out these things, not overly doing them, but you need them to be able to practice and probably make the living that you want to make. A couple other points on independent practice, and hopefully some of this resonates with people. Independent practice requires great staff, great back office, great payer contracts, which are constantly challenging and constantly changing, and often local market power, which goes back to this concept of, even if you're working with a health system group, you want to be with a great group. You don't want to be more or less, you want to be with great fellow practitioners. I think it's probably a better way to practice great medicine and also a better way for financial stability. But in the private practice setting, very much so, you need to ultimately have local market power, but also great staff, great team, great business. You're running a business as well as running a practice. There's a great piece by Dr. Daniel Choi, who's an orthopedic spine surgeon, I believe, but talks a lot about how business and entrepreneurial skill is critical to independent practice. It's critical to the very small practice. It's critical to the larger practice. The larger practices, you have this constant trade-off between sort of true alpha leaders and true servant leaders. And it's not that there's one right answer, the alpha versus a servant leader, but often to be a leader amongst lots of other leaders by nature. And if you're looking at spine surgeons, orthopedic surgeons, everybody's sort of leaders by nature, generally a little bit softer, not carrying this huge stick and being a little bit more user-friendly to your partners and colleagues is usually a better way to go in the long run. We see some of the best leaders I've seen are incredibly gracious with their partners. The alpha leader, who is the busiest spine surgeon in the group or the busy orthopedic surgeon in the group, can be a great leader for a period of time and comes with great credibility because he or she was so busy, but at the same time often wears out their welcome over time. We're sort of the servant leader. And I think about servant leaders in spine, people that have done this tremendous job of training so many residents, so many fellows, and those residents and fellows still come back to them constantly for advice. It's that kind of person that's able to handle themselves in a way that often becomes the best long-term leader for these groups, as opposed to the one who's got the biggest caseload, the biggest practice, but it maybe have the biggest ego as well. The people that are great, that can hold their ego in check, often become the best leaders of these groups as well. And people see whether they believe that as well. In terms of back treatment, back pain, at the end of the day, there's estimated $50 billion a year spent on back pain in all forms. Obviously, payers are constantly trying to move that away from surgery and move that to other types of things. It's almost like this, there are so many things that are good for patients, and payers could come up with a billion different reasons why they pretend like they're not good for patients. And it's not that some spine surgery is not overdone. And there are, of course, in any field, some cowboys that do far too much of what they should do, who there's certain doctors, of course, I'm in Chicago, there's always a couple doctors that you don't refer people to because they've never seen a spine they don't want to operate on. But at the same time, the payer game is one of complete sort of, and no offense to the payers in the audience, but it is almost always based on when they talk about quote unquote value-based care, it generally has nothing to do with value-based care. It has something to do with payer profitability. And it's not really about value-based care. It's about, can we cut down the cost of stuff and avoid paying for stuff? And that's why the pre-auth thing has become such a battle and such a war amongst orthopedics and spine and spine surgery. The last thing I'll say is, again, I got Medicare Medicaid payment. One of the challenges of spine surgery and why being part of a system, being part of a large group, and there are some great groups that are self-pay and avoid the whole payer thing generally in total, but being part of a larger mid-sized group, you're constantly having to deal with commercial payers because Medicare payment and Medicaid payment generally remains too low. And so you sort of need a large enough group to have a bulwark against your payers and be able to manage your relationship with your payers and not be completely taken advantage of, or be in a spot where you can't do nearly the number of procedures that need to be done on your patient population because you don't have enough because payers won't pay for it. So generally, we see people moving more and more towards mid-sized groups, trying to be dominant groups in their area, where there's a real reason for being, where at the end of the day, we talk about the same with regional health systems. You want to be in a spot where it's very hard for patients and payers to go around you, or if they really want to go around you, they got to go far for it. And that's the spot you really want to be in your private practice. I know I've quickly used up my 20 minutes. I'm a lawyer by background, so if I talk for 20 minutes, we typically bill for 60. No, I say that facetiously, but I obviously, I hope I've hit some topics that are important. I think in the long run, and people developing their practices, oh my goodness, decide what you're going to be great at, decide how you want to practice, what's important to you, take care of your physical and mental health, and keep your spending in check, because in the long run, you want freedom and anti-fragility, and keep your debt in check as well. Those are some of the overriding themes that we talk about all the time. I'm happy to take any questions. I'm so thankful for the chance to present to this group. I'm sorry I'm not there in person, but just thrilled to get a chance to visit with you. Obviously, it's free to subscribe to Becker Spine, Beckers Orthopedic, any of those things. I'm not here to sell any of that stuff, but thank you so much for having me. I really appreciate it.
Thank you. So any questions for Mr. Becker? I guess I could ask a question. Often in surgery centers, we're driven towards having high efficiency And it's a great thing for both the surgeon and the patient to be in an efficient place and get things done. But there may also be the potential concern for bias in terms of having maybe sicker patients that may not necessarily be the best surgery center candidate, and there's some financial reward often to the surgeon for doing a case at a surgery center. Any ideas, given your legal background, on how to manage that conflict of interest in terms of profitability for the surgeon, yet lack of maybe best candidacy to be a surgery center patient?
Yeah, no, I think that's just an absolutely great question. I think what happens is, a surgeon of any sort, you know, if you're going to do cases in a surgery center, patient selection is very, very important. I mean, any place you're going to be where you don't have the amount of backup you have when you're in a hospital center or right connected to a hospital, patient selection is quite important. And I think most people are quite familiar with that. I mean, you just don't want, if something happens with your patient, you want to be in the best spot possible. The second thing is, with a surgery center, profits are split based on ownership, not based on who does what case. But there's still pressure on surgeons. Spine surgeons face this because a lot of spine surgeons go back and forth where they could do cases at the surgery center, what's going on with payers, and lots of other reasons. And at the end of the day, your ethics and patient selection and making sure that the center is really equipped to take care of your patients is just so critical. You've seen huge move to spine surgery. You've seen huge movement of total joints to surgery centers, more and more cardiovascular procedures. But as a surgeon, you at the end of the day have to sort of filter through all the different pressure, all the different noise, and make sure that you feel like you're really taking care of your patient in the best place for that patient. And just, you can never sort of, that's just has got to be critical point one. And I think most surgeons are quite aware of that. The more you get yourself in a situation where I see surgeons in trouble is they've built out a spine surgery center with just a couple of them. They don't have enough cases. And so they start to push the envelope a little bit because they want to make sure they're keeping their surgery center going and working and making sense. And you want to avoid putting yourself in those kinds of financial pressures. I mean, most people are good people, and that's when they end up in trouble.
Yeah, yes, Dr. Chua.
Yeah, just one added comment. Scott, thank you for joining us. That was a great talk. I think there's this idea that it's either in the hospital or at the surgery center as an outpatient spine surgery, but there's something in between, which is, as a young surgeon, develop your craft and do outpatient surgery at the hospital. There is such a thing as outpatient surgery at the hospital. And if you really pick your craft, pick your surgical indications, do good work, make sure you have postoperative protocols and patient safety and education, you can then transition into an ASC where there are some of those other pressures. But you can cut your teeth on doing a high volume outpatient surgery at the hospital.
That's a great point. So anyhow, I think that's all the time that we have right now. But we appreciate that dimension of this talk, because it's definitely something good to listen to and understand, and we appreciate it. Thanks very much.
Thank you, folks, very much. What a pleasure. Thank you.